So once you've got your data and you've communicated it in all these wonderful ways which Ramani has just mentioned, how do you then translate it into improvement within your hospitals? Because we know that's the hardest bit. We've heard 3 great case studies this morning from the first session, and it sounded pretty easy, but I think we all know, I'm sure it wasn't easy, and it must have gone wrong a number of different times. So for the next few minutes, I just want to think about what lessons we can learn from each other and from the literature as to how to try and overcome these barriers. And it's salient because of lots of results and evaluations published, for example, into the EPOC study this year in the perioperative setting in the UK, where a quality improvement intervention was tried to be deployed at scale in a very rigorous fashion, but there was found to be no benefit for those patients who were involved in the intervention group, which was potentially a pretty depressing thought. But fortunately, the study group also did some process evaluations where they asked people on the front line as to what they felt about the study and what they learnt from it and what they felt the challenges were. And my reading of all of the various studies, some of which were just published last week, so hot off the press, were that the challenges really fell into these 3 categories: data collection and feedback locally, clinicians feeling that they have insufficient time or resources or institutional support to engage in these kind of activities, or indeed engaging their colleagues to go over and above their own work plans to help you with whatever project you're trying to do. And these themes will be familiar to all of us here today, and they're not going to be going away, and I don't have any magic bullets to make them go away. But there are some positive stories which we can learn from to try and navigate our way through this minefield of barriers. And so I've got 3 suggestions just to talk about this morning. Firstly, to adopt a multifaceted approach. Secondly, to collaborate, as Ramani's just mentioned. And then lastly, to really focus on our own local context. And so I want to think about these 3 now in just a little bit more detail. So by a multifaceted approach, using the EPOC paper published just last week, the team looked at which of the 6 strategies local sites used to try and get QI going in their hospital. So they were recommended 6 individual strategies, which I've divided into technical type strategies, looking at how they use their data or analyze it or share it, and then social type strategies, how they engaged the right people and formed a team. And the results, not surprisingly, was that if you used more of those 6 individual strategies, then you were more successful in improving clinical processes on the ground. It's difficult to prove quantitatively because this is perhaps not a quantitative type of field, but I think that's plausible and I think that's applicable to the kind of issues and settings we've been talking about this morning, particularly paying attention to the social type of issues which the frontline staff really felt that they had wished they had spent more time engaging with when they were doing the EPOC work. So secondly, collaboration, which has come up a number of times this morning already. And we all know in these times of rota shortages and shortages of resources that we will benefit from working in teams and using each other's enthusiasms and skills and capacity. But sharing data is perhaps one thing we could do today as a specific thing in the specialty-specific working groups this afternoon. We've been very careful not to publish individual sites' PQIP data, but we would encourage you to find a trusted friend and perhaps share your own data or issues or solutions, which hopefully will be mutually beneficial. Collaboration obviously can be internal within your own hospitals, and we've heard about the importance of the whole MDT engaging in this kind of work. And patients, we've touched upon. As a profession, we're probably not very good at engaging patients, and I think we should try and focus on that more going forward. And then externally as well, and there are lots of already well-tried and tested networks which PQIP data and issues could feed into, such as trainee networks or the academic health science networks, for example. And one example of that, a relatively simple but hopefully repeatable type of example, was in Bristol, where a group of trainees, the 7 Trainee Audit and Research Network group, I think, looked at anemia. And they looked at rates of preoperative anemia using their PQIP data and relevant processes and outcomes. They shared that within their region, within a number of different hospitals, and then calibrated it against the national PQIP data set and have mapped it back to differences in pathways in their own hospitals, and they're now going to take that forward to try and improve those pathways in their various hospitals. And of course, collaboration or collaboratives are not a new thing. Within the perioperative setting in the UK, the Emergency Laparotomy Collaborative published some positive results last year. And for example, in the US, the Michigan Collaborative has been very successful. And there's a growing evidence base that collaborating for improvement can be very productive. But the caveat to that is that you can't just copy project from hospital A and paste it into hospital B, because you'll get different results because of the different contexts. And we need to have this, we need to be mindful of the situation in each hospital in terms of resources, challenges, opportunities, and priorities. And I'm sure we all think about this in an informal way day to day. But if you wanted to think about it in a more formal way, or perhaps a more objective way, there are a number of academic frameworks which you can use. And the one that I would signpost you to is one called the MUSIC framework, which is the model for understanding success and quality. And there's a new and improved version too, just published last year. And that can help try and objectify some of the opportunities or challenges in your own hospital in terms of improvement work. And why is it important to look at context? Well, crudely, it can help try and target your clinical improvement work to the context that you're in. So are you trying to improve something that's incredibly complicated, such as theatre efficiency or hospital efficiency, or are you trying to pick a perhaps more improvable, discrete part of the clinical pathway to try and improve? And those two objectives might require more supportive contexts depending on what you're trying to do. And also, the social aspects of change, which we've talked about a little bit already. It needs to be teamwork. There's a huge amount of interpersonal skills and communication and coordination that is needed. And for example, you might want to think about how improvement work interacts with clinical leadership, with how the morale in your own departments might impact upon improvement work or be impacted by your improvement work, and who is owning this clinical work, this improvement work. And PQIP, this is my back of the envelope schematic as to who might be involved in PQIP in your own hospitals. And of course, it will vary by hospital depending on where you are. And I've divided the groups into 3 categories. You guys, many of which will probably be sitting in the green category, so you're your local PQIP leads. People on the front line will be probably involved in trying to collect the data so far, but we want to try and get them involved in the improvement work going forward. And then in the yellow, you've got all the important people who may or may not be aware of what's going on with PQIP in your hospital so far. And I'd say that there are probably 3 target groups, which I suspect not many of them are being involved in PQIP so far in your hospitals. Firstly, in the yellow category, you've got the quality and audit groups. So far, PQIP has been a research study, but as I'm sure you're all aware, now it's going to be reported in the quality accounts. And your local quality and audit groups will have very well-established relationships with their quality accounts, and they'll be interested in trying to help you gather that data and potentially create some success stories from that data. So I'd encourage you to engage with them as early as possible. And the other 2 groups within the green category are the local PQIP management leads and improvement leads, because we know that trying to deliver any improvement without support of management, or maybe without the methodological support of your improvement experts locally, can be hard. So thank you very much. I think we've got some questions now, and please do talk to me or any of the other team if these issues are interesting to you. Thank you.